much. And are these my slides? Yes. So thank you so much, Viraj, for giving an opportunity to discuss HCC, which has lately become our favorite. And we have seen the journey in last 12, 13 years that we had nothing but sorafenib. Then came Reflect. We were very easy and very comfortable with lenvatinib, with non-inferiority Reflect. And then we had this I'm Brave, very brave to start with. And then we have a plenty in second line, which is Resource, Reflect, Reach, Resource and Reach trial, and a couple of checkmates and keynote trial. So I'll straight away start with Dr. Randeep. So this patient who is a hepatitis C, CLD, hepatitis C related CLD, viral loads are less. He was kind of a surveillance with his gastroenterologist, and one sudden day he had this kind of tumor, and there's no radiologist here, but yes, it was a pretty large tumor, bilobar, multifocal, with a big lymph node looking like a structure which was extrahepatic, but it actually was a portal vein thrombus in the main portal vein. And his bilirubin is 0.9, albumin is 3.9, no ascites, PT-INR is normal, no ascites, no encephalopathy. So to make your life easy, he is child PUG A, performance status good, not on routine surveillance, he got some pain in the right hypochondrium, and this is a scary PET scan. How to proceed? Yes, Dr. Randeep.
So Ankur, I agree that this is beyond the lines of local therapy, but I would still in an MDT discuss once because we all know that, of course, this is a very big thrombus for the SBRT to resolve, and also I don't feel if it's a bilobar disease, this will be ever subjected to even tear in the best of the therapy. But still, after the concept, after a consult, at least from the intervention radiologist, if they say yes, the radiation oncologist and others, which most probably in an MDT, to my mind, this will be no, the patient will come for systemic therapy. But I would still like to give a chance, which may be less than 5%.
So Dr. Seema and Dr. Dinky, followed by Dr. Vikas, who manages the show at your institute? I don't at my institute. I don't. I'm sitting in my, with a decade of practice, 13 years of practice. I still not the favorite with my team. I am not the referral point, but there are many referral points, but the burden of hepatocellular cancer in my institute has increased. Still, I am not the show manager. So who manages your hepatocellular cancer, and how does the patient reaches you at what point, at what stage, and you are comfortable with that stage or not?
Sir, at our institute, if the patient reaches us through gastroenterologist, first they always go to a gastroenterologist, and if they are diagnosed in advanced stage HCC, then they get referred to us, and they are non-resectable, then they remain with us lifelong, fortunately. And
so, Madam.
So basically reference come from a gastroenterologist, and after that a surgeon for a potential resectability and maybe a potential localized treatment like ablation or TACE, and unfortunately after they progress on that, then they come to us. So they come
Dr.
to us.
Vikas.
Yeah, I also agree that most of this patient will be taking treatment under the GI physician. So they are one who diagnose, but sometimes they send direct to the surgeon rather than to medical oncologist.
So I differ. So if I see the trend, so these all hepatologists, gastroenterologists, now we have hepatologists which are different from gastroenterologists. We see intervention radiologists, we see nuclear physician who are actually playing their part in the community, in their referral center, and we see a cumulative occurrence of hepatocellular cancer in a institute brought by a surgeon, brought by a medical oncologist, few are got by intervention radiologists who are showing their way somewhere in the periphery or in different hospitals. So it is a multi-speciality physicians bringing that burden of hepatocellular cancer in that institute, and Dr. Rao. So once a patient of such kind comes to you, so you take your decisions on your own, or you go back to these all physicians and nuclear physician and intervention radiologists. How much time do you spend for these patients to actually decide what should be the treatment, and what are the broad categories by which you decide what is going to be next?
So from my institute, I will be the last person to be referred by this liver patient. Okay, all the hepatologists, liver transplant surgeon, even the interventional radiologist discuss everything, even in the multi-tumor board, and then they refer the patient that only in the last stage it's multifocal, we cannot do and touch and everything. Then they refer the patient for only as a palliation.
So how often you go back to them again?
No, always, very rarely I go back to them.
You rarely go back to them. No, you rarely go, as a physician, you don't go to your PET scan department, don't go to your intervention radiologist, you don't speak to that hepatologist for these patients, or you will decide the fate of this patient?
No, I will be the last person that will be referred.
Once the patient of similar stage comes to you, you will go back to them or not?
Yes, definitely.
So Dr. Randeep, how will you go up and what factors you will decide?
See, as I said that a bilobar disease with a very large portal vein thrombus, if the patient is primarily coming to me with this picture, I would definitely counsel him that a local therapy is not possible. But yes, that doesn't mean that the consult to the IVR is ruled out and a radiation oncologist is ruled out. They will still be they will be sent for a consultation, or in the MDT they will be consulted once, that if not now or later, are they thinking of loco-regional therapy, so that the intention is clear. But yes, simultaneously, when you are sitting in a multi-speciality setups, you also have to take a lead as a physician and do guide the patient that the chances are very less of a local directed therapy.
So this by definition is a non-metastatic hepatocellular cancer in a setting of hepatitis C CLD with no esophageal varices, with child PUG A and performance status good. We get these patients at times. It's not that these are rare. So majority of our patients are child PUG B, early B1, late B. And so what is your experience, Dr. Vikas and the ladies, by doing this? Is a portal vein thrombus, main branch, extrahepatic disease, major vessel involvement as per the new I Am Brave and many other Reflect and Resource trials. So would you consider this patient an attempt for tear or an SBRT to the portal vein before going for, it's an unresectable, it's not a transplant candidate, so you will go for these local therapies in such patients, or you will go straight away with systemic therapy? Madam and Dr. Vikas.
Local therapy, if it is feasible, yes.
So how do you decide a local therapy? So there is a selective taste, there is a taste, I'll come to you, Mangla. So there is a taste, there is a tear, branch portal vein, main portal vein. How do your intervention radiologist and your nuclear physician decides on that?
Basically, we discuss in MDT, and then it's, I think, their call to decide on whether to go for which.
So Mangla, can you throw some light? You can take a mic, this mic is okay.
Ankur is trying to bring forth the point is that it is extremely important for everybody to come together. These are difficult scenarios, and everybody has to come together and figure out what is best in the patient's interest. When we look at all possible treatment modalities, extent of tumor in patients with CLD is just a part of the whole problem. You have quite often a liver which is failing as well, wherein you would have to kind of start treating the liver first before you are really able to start treating the tumor. When it comes down to options, there are defined situations wherein you would use certain things, and a lot part of what we are finally able to do to that patient would depend on what's the child status of that patient. So at this point in time, it will be good to, if, as Ankur said, if the patient is Hep C, get the gastroenterologist on board, do a HCV RNA, start treating it.
No, viral load is less. He's child PUG A, performance status good, main portal vein, big thrombus
I
sitting.
think the options in this scenario would be two. One, you could consider a tear, which would probably be one of the best possible scenarios, the safest thing to do. But then, quite often in our country, cost becomes an issue wherein you could use SBRT and then kind of pile something onto it later as things evolve.
Dr. Rao.
Because the volume is such a big, you cannot plan for SBRT.
No, SBRT just to the portal vein tumor thrombus.
No,
You
that's
wouldn't
it.
try to irradiate the entire tumor. You just try to irradiate, because if the portal vein opens up, then probably later you can do TACE. So all those options open up once the portal vein opens up.
This is a small result of an paper published in 2020 where the rate of getting that portal vein dissolved if SBRT is given to that thrombus is as high as 30 to 40%, and we have seen child PUG improving when the portal vein dissolves and the ascites disappears and the liver function improves. So this all has been done. So Dr. Rao, so we have SHARP, we have REFLECT, and we have I am brave as a category 1 recommendation for a metastatic or an unresectable HCC. How do you decide all these, one out of 3? All are right.
First, the patient affordability is a very, very important thing.
Patient is the richest man on the world.
Then we go for atezolizumab and bevacizumab.
So all my panelists agree.
Yes, we also have durvalumab, tremelimumab now approved, though we don't have the drug available. So IO are the next big things. But yes, they go for atezo and bev with the good, the controlled viral load. And childpox, yes, I think this patient shall be subjected to atezo and bev as the first option.
Dr. Vikas?
So even for Atizo and BEP, there can be subset of population who will be more benefited as compared to the population like hepatitis B related tumor or the baseline AFP less than 400. Like this patient can be benefited more as compared to the other one.
Yeah. So Anant, I would like your help. So how do you decide? Are there any factors in your mind post that Nature publication that NAFLD or an alcoholic liver disease may not, or a hepatitis B or hepatitis C related say, maybe because of that inflamed phenotype, the response with that atezo-bev, the recruitment, restoration of the endothelium and this Treg lymphocytes working on that. So do you think that inflamed phenotype, which is well read in RCC, head and neck cancer, lung cancer, can be applied in hepatocellular cancer? And do you differentiate NAFLD, alcoholic liver disease, hepatitis C and B when choosing Lenva, Sora or atezo-bev?
Make judgments on treatment because that's only hypothesis generating. I don't use it. The one thing I do ensure is that hepatitis C and B are controlled before I start any treatment. But I don't use etiology as a marker for treatment, no.
I don't have that slide. So there is a Nature publication which says that alcoholic liver disease and non-alcoholic fatty liver disease may not respond to this combination because there is no Treg inside, so that the immunotherapy may not act as it acts in a hepatitis B or hepatitis C related CLD, which have given a chronic inflammation, and this chronic inflammation related CLD can respond to. And this was the I am brave forest plot, which says that hepatitis B and hepatitis C related CLDs, so these 2
Yeah.
points. So the non-viral HCC, they were not as much as responding to atezo-bev as hepatitis B and C, and Nature paper emphasized on that we can choose it.
The same thing was seen with sorafenib also.
Yeah.
Patients with hepatitis C probably did better with sorafenib compared to hepatitis B. So those differences are, markers for response. But I'm not sure whether you can choose treatment based on that. That's all I'm saying.
Yeah.
I agree with you though.
So any of the panelists,
And now we have an updated analysis of this trial, and they showed that in non-viral etiology, hazard ratio for OS is almost more than 1.
yes. So then I was going to say that updated I am brave 150 say that when it is a non-infective etiology, the hazard ratio is crossing, and this subset may not benefit. So even if being it's a rich patient, affording everything, Lenva or TKI plus, or that TKI plus Pembro study, which was ASCO or AACR.
Lenva Pembro is negative.
Yeah,
so
it was negative, but that forest plot showed that,
Yeah.
the waterfall plot showed that the disease control rate was too high.
Very good, yes.
So Ankur, we don't know even sorafenib and lenvatinib, especially sorafenib Asian trial as well as others. There was a plenty of patients who were hepatitis B positive, and that's why it is said that these TKI worked. So we even don't know how well they will work. Sorafenib and lenvatinib in a NAFLD. Equally, that data is not there for them because the Asian subset of the SHARP Asian showed better advantage, but there were more patients who were having more hepatitis B in Asia.
So 1 point more. So if given a chance and the patient coagulation profile and liver functions allow you, and there is a classical hepatocellular arterial venous washout, chronic liver disease, alpha fetoprotein more, do you want biopsy at any point of time? Now in IO phase, IO era, a biopsy before starting these. So if given a chance, would you biopsy, or you will not say that the diagnosis of hepatocellular is made, let's start the treatment?
I would not do a biopsy until and unless the radiologist raises a doubt in my mind. And I have once or
No,
twice
I'm saying
burnt.
there is no doubt on the
So no
diagnosis.
biopsy, but yes, even if the slightest doubt, I have done it. And I will tell you why I am saying this, because I had two patients who had hepato and cholangio, that is called as
Mixed
it's a
variety.
hybrid.
Mixed variety.
It's a hybrid hepatocholangio, and the TKIs and others, they take a second chance in the hybrid hepatocholangio. There you have to go for a chemotherapy, which is more like a cholangio, and then these regimens. Otherwise, if there is no doubt, then definitely no need of biopsy.
Dr. Rao.
Because it's HbS-AG positive, I definitely recommend biopsy for the patients.
Pardon?
HbA positive,
Okay.
then I will definitely
So
recommend.
Viraj, you can't hide. At this point of time, would you, I know you are a biopsy man, so even if the diagnosis of HCC has been made, do you want to know the biology of this HCC to prognosticate, predict whether to go for Lenvas or Afineb, Atezolizumab? There's no literature on that. But yes, the world is moving towards pathology. They want to predict and prognosticate this HCC on the basis of simple IHC and simple histopathology. Apart from volume and the alpha-fetoprotein, which could be a predictor and prognosticate, the world is moving towards lymphocyte-rich HCC, lymphocyte-depleted HCC, beta-catenin, which is a simple test. ILBS has started doing this test. So these are the markers which can predict very easily. And I was sitting with Excel Grothi in Dubai 6 months before. So the world is moving towards biopsy to know whether this patient will be responding to IO. And so there are many combinations of IO plus TKI or IO will be coming, which may predict in future that this is an inflamed HCC or a non-inflamed HCC. Yes.
Right, among these, beta-catenin is the one which has really shown a very good advantage with the Nivo-EP in the second line. I don't know about PDL1 and Tregs and other inflammatory, but beta-catenin has definitely shown that they respond very, if high beta-catenin with a simple IHC test, if ILBSs are doing, it's great, that they do respond very well to IO.
So coming on to I'm Brave 150, just 2 minutes left. So this study was actually very brave enough because 20% of the patient were high risk. They have involvement of main portal vein, which is called as extrahepatic disease, major vascular invasion, and more than 50% of the liver occupying tumor. So in this high risk subset of metastatic or unresectable locally advanced hepatocellular, I'll show you one more graph. So the OS benefit was doubled up. It was 6.5 versus 13 months when I'm sorry for this slide. So the survival was 6.5 versus 13 months when Atezolizumab was given in such a high risk when main portal vein was involved, the extrahepatic disease were there, and the tumor burden was more than 50%. So there was a splitting of the graphs, and 13 versus 6 months in this subset of the patient. So Dr. Randeep, before starting this combination Atezolizumab, so what precautions do you take in hepatocellular cancer? Very easy. I mean, it
I
should
think
be
one of the most simplest is to do an endoscopy and rule out uncontrolled varices. If it's a hepatitis B positive, you need to rule out that there is not a high viral load of HBV, HCV, and of course we know that in HIV immune deficient patients we can't, someone who's having a florid HIV you can't give, post-transplant you can't give, and systemic immune therapy,
Yeah.
systemic diseases like SLE and
around
other
20 to 25% of the patient on I'm Brave were having esophageal varices, and they were being ligated or before.
they learned during the trial course that they bleed.
And Dr. Vikas, what lessons you have learned regarding the toxicity profile of Atezolizumab in your HCC patients?
So to be frank, I have not used in many patients. Only 2 patients I have used, that too following someone. Like someone has written and I am just giving the therapy. So what I am feeling that patient, out of 2, 1 patient progressed very fast within 2 doses of therapy progressed. 1 patient is still continuing, and once he developed colitis, but fortunately recovered and continuing still.
So hepatitis during the treatment, grade 3-4 hepatitis has been documented in 20% of the patient, which is pretty high, and any grade hepatitis is 43, and with this hepatitis, the bilirubin level goes, and suddenly the childhood status changes. So I recall two of my patients who actually died with acute hepatic failure between second to third dose of atezo-bev. So it may look very easy drug when it passes on well, but these complication hepatitis as a lab abnormality and frank hepatic failure I have seen in two of my patients, and it was a frustrating and embarrassing moment for us. I think we have consumed the time, and if there are some leading questions from the panelists or some faculty.
I just had one question. When IO versus IO VEGF? Panelists or the moderator? Now we have both options.
Yes. So IO and IO-BEV. So atezo and bevacizumab have a synergistic phenomena as we see in ABCP in lung and IO plus BEV. So there's a two different mechanism which may work in hepatocellular. But yes, Nivo-EP combination.
Can you jot down a patient where there is no atezo-bev and durva-tremi?
I can't differentiate which patient to start with.
Probably
durva-trem or atezo-bev.
contraindication to VEGF. That's the only thing we can think
Contraindication to VEGF may deviate me towards this IO combination, otherwise not.
Otherwise not. Perfect. That's a good take-home message.
Yeah. Thank you so much for your patient listening, and thank you to all the panelists. Thank you.